I'm going to talk about, I don't want you to practice on me. I'm a surgeon. I've just coming to the end of my training, my arduous training in the UK of almost 12 years. And I just want to take you back to many years ago, about 11 years ago, when I just finished medical school and I was doing my first job as a general medical house officer, working in a small district hospital just outside London. And I knew at that stage I wanted to be a surgeon. That's all I've ever wanted to do. And so I was doing a general medical job, and being a surgeon, what was I interested in? I was interested in doing as many hands-on procedures as possible. And so I'd worked with my boss, and we were working on a cardiology firm. I'd put in a few central lines. I'd put in a couple of pacing wires. And just after a few months, we were getting on well, and I said, well, do you know one thing that I haven't done yet is done a lumbar puncture or a spinal tap. And it's something that, you know, I'd seen my boss do once or twice, and I said, you know, next time a lumbar puncture comes along, needs doing on a patient, do you mind if I do it? And he said, yeah, fine, no problem, let me know when a patient comes along, and I'll come along and I'll take you through it. So a few weeks later, I was on call. I remember it clearly. It was a Friday evening at about 6 o'clock. And a patient came in, a youngish lady. She must have been sort of in her mid-20s. She worked for one of the airlines at the check-in desks at Heathrow Airport. And she'd come in with a severe headache, a little bit of neck stiffness as well, and a pyrexia. And so we needed to do a lumbar puncture to exclude meningitis. It was probably unlikely, just looking at her, but that's what we needed to do. So I spoke to my boss. He came down, and he said, great, Raj, get her ready. So we put the lady in the position, as you can see here. And as you can see, I need to sort of get between the vertebrae and put quite a long, sharp needle in to get some of the cerebrospinal fluid. So I had the patient there, and I was feeling down the vertebra here, and I was just saying to my boss, oh, well, okay, I want to make sure I go to L1, L2, something. He was like, no, a bit lower, maybe L4. Okay, fine. And then I was sort of getting the needle ready, and I was saying, yeah, you want me to do this? And then I was just about to put the needle into the patient's skin, into her back. And she just turns her head and says, why is he telling you what to do? Have you never done this before? And I didn't know what to do. And my boss obviously saw the situation, and he just said to the patient, it's okay, ma'am. He's done this plenty of times before. He's with me. He's doing fine. I almost froze, and then I just thought, well, what I need to do is get on and do this and do it safely and get the hell out of here. And so I did the spinal tap, managed to go fine. We got the fluid out, and the patient was fine, and the result was normal. She went home the next day. There were no complications. And normally, when I do a new operation or I've done a new procedure, I'm excited. I'm like, wow, I've managed to do that. Fantastic. And I didn't feel that same kind of excitement after having done this. I felt awful. I just, you know, I was doing this for the first time on this patient. She was my guinea pig. Something could have gone wrong, and I didn't even tell her that. And then we came up with the situation where she actually asked. And I completely froze, and my boss just took over and said, it's okay. And I then spoke to my boss, and I said, well, I feel really bad. You know, maybe I should go and talk to the patient. This isn't right. And he just said, well, how else are you going to learn? This is what you need to do. You need to practice on the patients, because otherwise you're never going to be able to do it. That's how he learned, and that's how the person who taught him learned. And that's normal. That's what we do in medicine. And that's how I've learned my surgery. over the last 12 years by gradually doing things with someone there assisting me. And I haven't been perfect. I've made mistakes. And that's the way we learn. And it's not just within interventional procedures. We also do this on the wards, when we learn during ward rounds, for example. And a lot of the time, we actually don't even consider the patient. We just get on with what we need, my needs, rather than considering what's wrong with the patient. It's not the patient has this problem, it's the API or the coli or the colon cancer. And just to put a lighter note, I'm just going to show you a short video clip that I hope you'll enjoy.
Now, you. When we've cut through the skin, what's the first substance we shall find?
Subcutaneous fat, sir.
Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time?
10 past 10, sir.
Basically, that was a short video clip of, this is Sir Lancelot Spratt here from the Doctor in the House movies. And it's about him teaching his registrars on a ward round. And you can see here the patient. He doesn't converse with the patient at all. He just talks to his trainees. And the patient is completely ignored. And that's really how a lot of learning takes place. Now, I said I'm a surgeon, and I'm particularly interested, as part of my research, in training. And one of the key procedures that we learn when we start to train specifically in laparoscopic surgery is to remove a patient's gallbladder. I'm just going to show you a brief video clip of one of the trainees who works with me removing a gallbladder. And this is from an animal model. And as you can see, it's quite difficult. I mean, laparoscopic surgery is wonderful for patients. It gives them smaller scars. It reduces the time they spend in hospital. It also gets them back to work quicker, so they start paying their taxes much quicker. But as you can see here, this is one of the trainees practicing on one of the animal models. And it's quite difficult. You can see that there's a fair amount of tremor there. He's having to dissect out this duct, make sure he doesn't damage anything else. And as you can see, cut the duct between the clips. And it's extremely challenging. And the first time I held a laparoscopic instrument was when it was inside a patient. And the boss just gave it to me and said, here, hold this. And again, it's sort of akin to what I mentioned about doing the lumbar puncture. And it's very challenging to learn these skills, and even more so to learn them in a clinical environment where there's a whole team there, and there's a fairly significant chance of error. And thank you. And what we know is with the introduction of laparoscopic cholecystectomy, there was an error rate in terms of common bile duct injury. Now, injuring the common bile duct is pretty serious. If that happens, the patient usually needs another operation to fix it, may even get a stricture after the bile duct injury, and may even need to have a liver transplant because of secondary cirrhosis from the stricture. So it's a pretty significant life event for the patient compared to a straightforward gallbladder removal. With the introduction of cholecystectomy, this is a series of operations published in 91, so 20 years ago, by the Southern Surgeons Club. 1,500 cholecystectomies performed. And what you can see is, in terms of experience, as the number of procedures increases, the probability of bile duct injury gradually reduces, such that for the first 10 cases, it's very high. And by about 40 or 50 cases, it's about a third or a quarter what it is for the first 10. And this is something that we, as physicians, call the learning curve. And there are numerous papers. We're doing a literature review at the moment. There's about 700 papers that quote the learning curve and empirically measure it for a number of different abdominal surgical procedures. And it's something that's accepted, whether you're learning how to take someone's gallbladder out, whether you're learning robotic surgery, whether you're learning how to do a coronary catheterization. But the thing that's really not that open is this dot here is a patient, as is this dot here. Why does this patient have a 5 times greater risk of injury than this patient here? Because of the operator has done fewer cases. And the patient is not even aware that this is the current state of affairs. They don't know the number of cases that the operator has been done, yet we publish this data regularly in our medical journals. We all know if I wanted my gallbladder removed, I'd want to make sure I had someone who was down here. I wouldn't want to be this patient up here. So why do we persist with this? Why do we have patients in this early part of the learning curve? Well, you go back to me having to do the lumbar puncture. There's no other way. This is the way we do it. It's see one, do one, teach one. That's what we're taught. The apprenticeship model, which has been around for almost a century now. But there is another way. We can learn all of this outside the operating room. And you've heard a lot about simulation, I'm sure, and it's one of my passions, one of the areas that I really work in terms of simulation focused on surgery, but also for any other interventional procedures. And what this enables any healthcare professional to do, we've even taught nurses how to do endoscopy using simulation, is to practice the tasks, to even just get used to the instrument, which button to press. And you shouldn't be doing that when the instrument is in a patient. And to be able to learn those basic skills, to make as many errors as possible in this environment, so that that early part of the learning curve is completely negated. And that's what we've been working on. And we've used virtual reality simulators as well, which not only enable standardized practice on repeated measures, they provide objective feedback of performance. So you can actually then measure the performance of the surgeon and say, well, I'm not going to let you touch my patient until you've reached this level of skill. And that means you've moved away from that early, steep part of the learning curve. And just imagine if we told the patients this. I mean, they'd be amazed that we're doing what we currently do. When we first had virtual reality simulators, one of my predecessors in the department at Imperial, he used to go around and give talks, and there was a lot of backlash, actually. A lot of people said, these simulators, they're just computer games. You know, they're the same as in those days, the Nintendo, Sonic the Hedgehog, these kind of things. So he was a very, very clever chap. And what he did is he took one of these simulators to the Trocadero Centre, which is a big gaming centre in the centre of London in Piccadilly Circus. And what he said is, if these are computer games, then the best gamers in the world are going to be better at this than any surgeon I can find. And you can see it made the news. In case you're confused, this is the surgeon. This is the computer gamer here. All right? And he's doing the task here. Same task that we had our surgeons, our trainees, our medical students do. And as I said, this measures performance. And you can see, in terms of errors, the computer gamers made significantly more errors than our students, trainees, or surgeons. So this is not a computer game, because the best computer gamers in the world were worse than our medical students. This is something that is a surgical skill, and which teaches surgical skill. And there's plenty of data out there now. Cochrane reviews, there's a recent review in JAMA published on the benefits of simulation. So we know that it absolutely works. And Going back to the learning curve, one of the earlier studies that I did was to look at the learning curve on the basis of simulation versus standard training. And if you remember back to that graph I showed you of the lap chole, so this is the learning curve of surgeons having done no simulation training, so the control group. And this is the learning curve of trainees having done simulation on this virtual reality simulator. And what you can see is immediately that the VR train group reached the same level of skill by the 3rd session as did the control group by the 5th session. So we've already reduced the learning curve by 40%. That's a great efficiency saving. But even more importantly, if we say that this is the start point, so that's your lap chole number 1, and this is an arbitrary finish point, doesn't matter where it is, where there's equivalence between the two groups. With the benefit of simulation, this is now the start point here. And this gap here, which, if you remember, was when the majority of bile duct injuries happened, has gone. That's gone to the simulation lab. It never reaches a patient. It never gets to the operating room. And there will always be some semblance of a learning curve because however good simulation gets, we're not going to get to the stage where it's going to be identical to the patient. But it's much shallower, it's much flatter, it's much shorter. And not only is this going to be safer, it's going to enhance quality and enhance cost effectiveness of training, not just surgeons, but any physicians or healthcare workers. And what we really need to do is focus on, it doesn't really matter what type of simulation it is, or whether it's simulation indeed. Focus on this and go beyond that. Focus beyond just trainees. We can all get better. And there's really I have to say, a culture within surgery that I've experienced where it's about being good enough. If you're good enough to do the case, then you get on and do it. And there's not a culture of striving towards excellence. And it's really important that we try, during our lifelong learning, to strive towards excellence. And we can use a number of factors. We can use simulation, we can use warm-up, we can use mental rehearsal, we can debrief, something we're very bad at as surgeons. We can have the team huddle. And really what I think we need to do is look at surgery as kind of the dinosaur in terms of acquiring skills and trying to achieve expertise. And we really need to look at a number of other arenas, such as musicians, rifle shots, super racing drivers, grandmaster chess players. All of these guys, even though they're the world's expert at rifle shooting, they still train. They spend more time training than they do performing. They have trainers, they have coaches. They go on and on and on, striving towards excellence. And that's what we need to keep doing. So whilst the focus on simulation, yes, so far has been on trainees, it's there for everyone. And all these other techniques, everyone needs to use. Because we really owe it to our patients to give them the best. And I would really like to say that I don't think we give our patients the best at the moment. I think we can do much better. And there's a number of reasons for that. And when I was a medical student, I said I wanted to be a surgeon. One of my very senior consultants, very well respected, told me this little phrase, that a surgeon must have an eagle's eye, a lion's heart, and a lady's hand. So with that, I'd like to thank you for your attention.